and welcome back. This is Professor Truelove's Concepts for Nurses series, and I am Professor Terry Truelove. And in this episode, a continuation of the respiratory series, we will look at critical respiratory problems, things like pulmonary embolus, respiratory failure, and acute respiratory distress syndrome. Sources for this episode include Iggy's Medical Surgical Nursing and Sol's Introduction to Critical Care Nursing. You're looking at an example of a pulmonary embolism. An embolus is a clot or a plug of material that travels from one blood vessel to another smaller vessel. The clot then lodges in the smaller vessel and obstructs blood flow. An embolus in the pulmonary vasculature is now called a pulmonary embolism or a PE. This embolus may be a clot that is broken off from a deep vein thrombosis or a DVT. It could be a globule of fat from a long bone fracture, septic vegetation, broken pieces of catheters, or in pregnancy, amniotic fluid can be a cause of PE. However, you should know that most PEs do originate from a DVT in the lower extremities. When that embolus completely or partially occludes the pulmonary artery or one of its branches, that mechanical obstruction impedes the flow of blood. Now, the pulmonary circulation has an enormous capacity to compensate for pulmonary embolism. And this means that the lung vasculature is going to increase blood flow during exercise. And it's the reason that many folks don't even know they have the PE because they don't develop symptoms. It's only after we start to see what's called a ventilation to perfusion mismatch or VQ mismatch and the release of inflammatory response, such as prostaglandin, serotonin, and histamine. This inflammation causes constriction of the bronchi and the surrounding blood vessels. Now, what occurs at this point is blood starts to go further and further away from areas which could provide gas exchange. This worsens the VQ mismatch. Atelectasis and shunting now starts to occur, and it starts to impede its own self. In other words, it makes itself worse and worse and worse. Without intervention, eventually the VQ mismatch is so great that gas exchange is critically compromised. Risk factors associated with pulmonary embolus include prolonged immobilization, the presence of a central venous catheter, post-surgical intervention, obesity, advancing age, conditions that increase the tendency to clot blood, and a previous history of thromboembolism. Teaching to prevent the incidence of pulmonary embolism includes urging the patient to stop smoking, weight reduction, increasing physical activity, and if traveling or sitting for long periods of times, to frequently get up, drink plenty of fluids, and even consider anti-embolism stockings. Lastly, you should remind the patient to refrain from massaging or compressing the leg muscles, because that can actually break free the DVT, leading to a pulmonary embolism. It's one of the reasons we are discouraging you from actively checking for Hohmann sign when suspecting a DVT. You may have heard about the classic signs of PE, of dyspnea, hemoptysis, and chest pain, but they actually occur in less than 20% of all of the cases. Your most likely candidates are those patients who have sudden, unexplained cardiorespiratory complaints and previous risk factors for VTE. A relatively common symptom of PE is a sudden onset of dyspnea. Accompanying that could be tachypnea, tachycardia, pleuritic chest pain, a dry cough, and, like I said, in some cases, hemoptysis. Your cardiac signs and symptoms may include distended neck veins, syncope, cyanosis, systemic hypotension, abnormal heart sounds, and an abnormal ECG. In later and more chronic stages, you may see a low-grade fever, petechiae, and even flu-like symptoms. This chest pain may be aggravated by deep inspiration and may be accompanied by cough, crackles, and wheezes. There, in some cases, may even be a second heart sound and even atrial fibrillation. Laboratory assessment for the patient suspected of having a pulmonary embolism should include an arterial blood gas. And in that arterial blood gas, many providers will look at a PO2 FiO2 ratio. This looks at the ratio between the partially dissolved oxygen in the arteries and the FiO2 provided. The number should be greater than 500 millimeters of mercury at sea level. However, there is a lot of dispute on whether this is even an accurate diagnostic tool. You can use pulse oximetry for trending, but not for diagnostics. You should know something called a D-dimer. D-dimers are fibrin degradation products or fragments that are produced during fibrinolysis. Therefore, this is a very nonspecific test used to diagnose a PE. It's sort of a flag warning you, hey, something's wrong with coagulation. So you should remember, however, that a positive D-dimer assay can occur for other conditions such as infection, cancer, surgery, pregnancy, heart failure, or kidney failure. And so it should not be used as a definitive diagnostic tool, only as, again, a flag to warn you that something is amiss with the clotting process. Imaging can begin with something called a ventilation to perfusion scan, or a VQ scan, which is a non-invasive lung scan that calculates pulmonary airflow and blood flow. In this way, it may detect dead space from impaired perfusion of ventilated alveoli. So these VQ scans are reported as low, medium, or high probability for pulmonary embolus. Other imaging that can be used include duplex ultrasonography, high-resolution CAT scans, MRIs, and pulmonary angiograms. Management for pulmonary embolism, of course, includes oxygen therapy by whatever means necessary. This may include anything from a nasal cannula to a ventilator. Provide for continuous patient monitoring. Make sure you have good rescue IV. Continuously monitoring the pulse oximetry, and for drug therapy, the drugs to go to include anticoagulants or even fibrinolytics if the condition is advanced enough. Because your patient will be on either anticoagulants or fibrinolytics, bleeding precautions should be indicated. That means assess for bleeding at least every 2 hours, examine all stool, urine, drainage, and vomitus for gross blood, and test for occult blood. Measure the abdominal girth at least every 8 hours. Monitor lab values, and surgical management may include having to physically go in and remove the embolus, called an embolectomy, or providing a filter, like an umbrella, in the inferior vena cava, called an IFC device. Keep in mind that pulmonary embolus is quite dangerous and can prove fatal. Listed here, we have acute respiratory failure, which we will concentrate on. However, you should understand that there is another type of respiratory failure known as chronic respiratory failure. The difference is really the fact that in acute respiratory failure, this happens very quickly. It happens within minutes to hours, and there's very little time for physiologic compensation. However, chronic respiratory failure occurs over time, and this does allow the body's compensatory mechanisms to activate. You should know that a person who has chronic respiratory failure can develop acute renal failure in the presence of an infection or other types of stressors. Respiratory failure is a gas exchange issue where you have persistent hypoxemia, that is a PaO2 of always less than 60, saturations less than 90, and PaCO2s greater than 50 with pHs in the acidotic range. There are different mechanisms that can lead to respiratory failure, and one of them is called ventilatory failure. This is a physical problem of the lungs or the chest wall, or a defect in a respiratory control center in the brain. This results in either way in a poor function of the respiratory muscles, especially the diaphragm. There could be causes from outside or inside of the lungs, that is extrapulmonary or intrapulmonary causes. Changes in the calcification of costal and sternal cartilage will cause decreased chest wall mobility. Things like osteoporosis or spinal degeneration, kyphosis, flattening of the diaphragm, a decline in muscle mass are all examples of extrapulmonary problems, whereas the things like decreased mucociliary clearance, where the mucus cannot be expelled quickly from the airways, or a decline in surfactant production, a decreased effectiveness of the immune system, or a thickening of the alveolar capillary membrane are all examples of intrapulmonary pulmonary causes of respiratory failure. And the thickening of the alveolar wall is an example that could cause oxygenation failure. With oxygenation failure, there is simply insufficient oxygen of pulmonary blood at the alveolar level. While the ventilation remains normal, the perfusion of the lungs is decreased, and so therefore there is a right to left shunting of blood. What that means is that blood is arriving back to the left atrium without getting an adequate amount of gas exchange, so it has increased carbon dioxide and decreased oxygen. This leads to your VQ mismatch and low partial pressure of oxygen dissolved in the blood. As a compensatory mechanism, especially with chronic renal failure, you will probably see an abnormal hemoglobin as the body tries to compensate by increasing the amount of hemoglobin for the low PaO2. Patients who have pre-existing lung conditions, especially end-stage patients with COPD, chronic bronchitis, emphysema, even asthma attacks, can have what's called a combined ventilatory oxygenation failure. In this case, there is diseased bronchioles and alveoli cause the oxygenation failure, and the work of breathing increases. The respiratory muscles are now unable to function effectively. So the alveoli cause the oxygenation failure, but the weakened respiratory muscles cause the ventilatory failure. Interventional goals include maintaining a patent airway, optimizing oxygen delivery, minimizing oxygen demand, treating the cause of respiratory failure, and preventing complications. Therefore, the interventions are going to be directed around gas exchange, provide for oxygen, provide comfort by positioning and even giving pain medications. But of course, be wary of opioid painkillers because of their effect on the respiratory center. Things that work to reduce the work of breathing include relaxation, diversion, guided imagery. Teach about energy conserving measures such as periodic rests, scheduled resting, and activity splitting. And consider the types of medications to be used, most of which are going to be directed at anti-inflammatory and anti-immune responses. Maintaining a patent airway should start off with non-invasive positive pressure ventilation. However, if your patient is not able to maintain the patent airway, they should be intubated and provided with mechanical ventilation. Optimizing oxygen can be delivered in many ways, anywhere from the nasal cannula to higher FiO2. And proper positioning can go a long way to optimizing oxygen levels. Sitting the patient up or even to the non-effective side, that is, turning the patient to their non-effective side, can cause gravity to change how blood and oxygen interact. That will increase your ventilation to perfusion match and increase gas exchange. You should consider minimizing oxygen demand by providing the patient with adequate rest, avoiding unnecessary physical activity. Finding the cause of the respiratory failure is key. And lastly, you need to prevent complications associated. You might want to ARDS was originally identified as an acute illness manifesting with dyspnea, tachypnea, decreased lung compliance, and diffuse alveolar infiltrates on chest X-ray studies. Criteria as of 2012 include an acute onset of the condition within 1 week of another clinical insult, including things like motor vehicle accidents or surgeries, even infection or sepsis, bilateral pulmonary opacities not explained by other conditions, and an altered PaO2-FiO2 ratio. You should know that ARDS is divided into 3 conditions: mild, moderate, and severe. With ARDS, there will be persistent hypoxia despite using more and more oxygen. This is known as refractory hypoxemia. A decreased pulmonary compliance, that is a stiffening of the lungs. Dyspnea, non-cardiac associated bilateral pulmonary edema, and a dense pulmonary infiltrate seen on X-ray, known as whiting out. Your diagnostic assessment will show your lower PaO2 values on the arterial blood gases, the refractory hypoxemia previously mentioned, the ground glass or whited out appearance to the chest X-ray, the non-cardiac involvement on your ECG, and a low to normal pulmonary capillary wedge pressure when checking your patient's hemodynamic profile. ARDS is an acute and diffuse injury to the lungs which leads to respiratory failure. It is a two-phase condition. It includes the acute exudation response phase and the late phase of fibroproliferation. The acute injury causes an inflammatory response, and that inflammatory response cascades, changing the structure of the alveolar capillary interface, causing the changes associated with ARDS. Your patient with ARDS will usually require intubation and mechanical ventilation. The selection of the ventilator settings is going to be based on how severe the ARDS is and could include not only higher FiO2s, but something called positive end expiratory pressure. That is extra pressure at the end of exhalation. This extra pressure causes back pressure that can increase the size of the terminal airways and cause increased gas exchange to these very stressed out alveoli. You should remember that high FiO2 can actually cause an increase in the changes of the alveolar interface, worsening the ARDS, and PEEP can cause either volutrauma or barotrauma. Your respiratory therapy team may recommend non-conventional modes of ventilator therapy. Another way to improve oxygenation recall is to change the patient's positioning. You may have a patient on a ventilator that is required to be pronated, that is, turned face down. Again, to change where the air is versus where the blood is, combining them together to improve gas exchange. While there are no medications specific to treat ARDS, it is very common that these patients need to have adequate sedation, not only for comfort, but to reduce oxygen demand. Extra fluid actually exacerbates the problem, so unless otherwise indicated, these patients should be kept hemodynamically dry. The increased work of breathing associated with ARDS can really cost calories, so nutrition will need to be addressed. Case management is going to be focused on pre-existing conditions. For instance, the patient coming in with a chronic condition like COPD or cystic fibrosis will probably have a very different outcome than someone with an acute problem, such as a person surviving a traffic accident. Consider that patients with chronic problems are less likely to survive ARDS than younger patients with acute problems. In summary, ARDS is a condition that can lead to respiratory failure, and respiratory failure can affect all segments of the population. Critical care nurses must be constantly alert for signs of impending respiratory failure. Changes in respiratory rate and character, breath sounds, and blood gas values must be closely evaluated. Frequent position changes, good pulmonary hygiene, and careful attention to nutritional status all contribute to reducing the incidence of respiratory failure. And we have reached the end of this episode, but stand by, there's still one more episode to come. In the meantime, I hope you learned a little bit by listening to this episode. I hope you plan on coming back, and if you are, we'll see you then. Take care.